the fire department.
Hi, Barbara. Okay. So what we're going to do first is I'm going to give you Digi the floor for a second to go over how this works with public meeting law. And then we're going to follow the format of medical standards with medical standards subcommittees, and then REMAC with REMAC subcommittees to get through the whole meeting. So do you want to start and just kind of discuss how Zoom and the public health meeting law works?
Sure. So as everyone knows, REMAC and REMSCO are subject to both the open meeting law and the general construction law of New York State in terms of how meetings need to occur and how voting must occur. Generally, meetings are not allowed to be held remotely as we're having now. The governor came out with a directive that permitted all such meetings to be held using technology such as Zoom, provided that several things be done. One is a quorum still must exist. The Department of Health then came out a directive a little bit later saying that quorums could be waived specifically for items that deal with COVID-19 preparation. However, they did not say and define what a quorum means. It clearly doesn't mean that two people could get together, have a meeting, and make all the decisions. So I'm going to leave it for the laws in court at some later date to whoever wants to challenge what we do, whether or not we meet whatever minimal quorum we're supposed to have, but we have really no idea what that means because it was very unclear. The other restrictions are that the meeting must be recorded, which it is being recorded as we speak. Number two, the meeting has to be broadcast to the public live, which means that it has to be streamed as we speak. And I understand that we're streaming it to either YouTube or Facebook or something. I don't want to hear, Marie, that you're not doing it because we don't want that on the record. Let's assume that it's being done. Okay? I can't hear you, Marie. But
this is why you did it as our parliamentarian.
Right.
Well done.
Okay, fine. Number two, what I don't hear, okay? But I do want to tell you that if we do something today, which I doubt, that someone's going to come and challenge us in court, we will probably lose.
But let me just say, for any of our meetings, we have never done live streaming. We post it afterwards.
You never had to do it before, but now it says you do. I'm not a lawyer. I'm reporting to you. I just went through the same thing in the college, and we are going to be live streaming it on Facebook, or maybe for future meetings we should just do it. It doesn't cost you any money, and you can just do it. That way no one can interrupt. But in any event, and of course we're going to have roll call votes, as we normally have. Marie will have to go through the roll call. So it's being recorded. We have whatever quorum. I believe we have a quorum anyway, so I'm just looking at it. But I think that Marie should make a roll call vote now as soon as we finish talking. And other than that, we're doing everything we should be doing, and we can move on as normal. So we can have a regular meeting, and Joe, you're running the meeting, and Marie can take a roll call and recognize people as you wish. That's it.
What we're going to do is Marie is going to do a roll call. She's going to start with medical standards and then go right through the REMAC list to see who's on the phone. And then we'll go through our meeting. The only question I have is, Dario, are you on the phone?
Yes, I am.
Okay, so as soon as Marie's done with the roll call, if you wouldn't mind giving us a status update on what's going on. I know you've been stationed at the Javits Center. You can give us a little bit of feedback on how that's been going and so on. But let's get through the roll call first, and then we'll go to you. All right, Marie, take it away. You have to hit the unmute button, Marie.
You might want to unmute everybody right now for the roll call vote.
Okay, everybody's unmuted. I hope that we can all behave ourselves. Okay.
Hey, I'm so sorry, it's Glenn Data.
Hey, Glenn.
Sorry about that. This tech stuff isn't working for me. Sorry.
All right, Marie, go ahead.
Okay. Here it is. Okay, please answer when I call your name. Paul Barbara.
Here.
Here.
Jonathan Berkowitz,
Here.
Cindy Basilios,
Here.
Harry Koplovich, Joseph Bove,
Here.
Neil Samolovic, Wally Carter, Robert Krupe,
Here.
Jeffrey Douglin, Shiwen Lee,
I'm his alternate, Pasterko.
Shiwen Lee,
Yeah, I'm his alternate, Pasterko. Lauren.
okay. Reed Caldwell, Jason Zimmerman, Christopher Graciano, David Lobel,
I'm here.
Matt Friedman,
I'm here.
Jeffrey Rabridge,
Here.
Mike Redlener,
Present.
Joe Schenker,
Here.
Anthony Shalish, Rafael Torres, Jason Zimmerman, Nick Alexandru,
Here.
Give me a second. I just spilled water all over my computer. Why was it open? Close that.
okay, we can hear you. Glenn Asada,
I'm here, thank you.
David Benelli,
Present.
Dario Gonzalez,
Here.
Doug Isaacs, Brad Kaufman,
Here.
Barbara Aziz,
Here.
Kevin Ward. Kevin, are you there? Grace Cacciola,
Here.
Maddie Fong, John Graves,
Here.
Michael Vatch, Robert Ackerman,
Here.
Morty Lax,
Here.
Art Cooper, Robert Goldstein, Yadidja Langsam.
Yeah, Art Cooper's here. I'm sorry, I was muted.
Okay. Lou Marshall, Kevin Munjal,
Here.
Jessica Van Voorhees. Okay, that's it. We have a quorum.
That was for medical standards or both?
That's just medical standards.
Let's do REMAC as well, and then we'll
Okay.
get started.
Okay, I may call your name again, but, okay, Robert Winchell,
Here.
Joseph Schenker's here. Robert Ackerman, you said you're here, right?
Yep, I'm here.
Okay. And, okay, Nick Alexandru is here. Christopher Graciano,
Here.
you are here. Okay, great. Give me a second. Kevin Munjal is here. Cindy Basilios is here. Grace Cacciola is here. Dario Gonzalez is here. Glenn Asada is here. Bradley Kaufman.
Here.
Doug Isaacs, have you walked in? Nathan Reisman.
I'm here.
Kevin Ward. Barbara Aziz is here.
Here.
Samia McEachin. Allison Burke.
Here.
Jeffrey Rabridge is here. Reed Caldwell. Jonathan Berkowitz is here, correct, Jonathan?
Yes.
Louis Marshall. Michael Redlender's here. Laura Ivacoli,
Here.
Stuart Kessler,
I'm on.
Matthew Fink, Wallace Carter, Dominic Battinelli,
I'm here.
Efren Rendon, Peter Wire,
Here.
Paul Barbara.
Here.
Okay. David Benelli. Celia Quinn. Timothy Stiles.
I'm here.
Oh, great. Mark Cantor.
Here.
Sherry Sperry. Joseph Bove.
Here.
Sean Graves is here. William Fisher. Robert Krupe.
Here.
Jessica Van Voorhees. Art Cooper is here.
Yeah, up here.
Yadidja Langsam is here. Anthony Shalish? No, okay, let me just do a quick count.
Hi, Marie, it's Reed Caldwell. I'm sorry I'm late. I'm here.
Oh, great,
Marie, Nancy Benedetto is a guest.
okay.
Marie Martin Grillo as a guest.
Anybody else?
Matthew Smith is a guest.
Matthews.
Decline from the fire department.
Marie, Space Second.
Hi, okay.
Jim Downey as a guest.
And Zabar's here.
Matthew Lidner is a
Annette
guest.
Müller. Annette Müller as a guest.
Okay, let me just count so I can see if we have a quorum. 1,
Hi, Marie Spoke. I don't know if you got me.
Come on.
8. Whoops. 9. 11, okay, 12, 13, 14, 15, 16, 18, 20. Yes, we have a quorum. We have a quorum. We can go forward.
Okay. All right. So Dario, I'm just going to let you start. We're going to just do a brief update on what's going on at the Javits Center, and then we'll pass it over to David for the medical standards portion.
Okay, thank you. I'll try and make this not too long. So the Javits
Thank you for that
Center.
report. That was great.
Okay, goodbye. So the Javits Center is presently functioning as a semi-hospital, initially envisioned as a medical station, which is very different than what it's become. Sort of evolved into something totally different with labs, x-ray, and piped-in oxygen. If you look at so the Javits Center is accepting COVID-positive patients. It's considered a COVID-positive environment, so we're trying to limit it to those people so we don't convert anybody unless we have to. We can do testing there. If you look at the cumulative numbers for the Javits, it's 1,040. Presently, 205 patients in-house, 18 are in an ICU setting, discharged to date 799. The Comfort is seeing a cumulative 178, presently has 59 patients, 37 are in an ICU setting, 121 have been discharged to date. So it's still functioning. There is change in staff. DOD will be here for the near future. Public Health Service is leaving. We are looking at where this is going to transition to and how it's going to function. we're still looking for patients to decamp from the facilities, but we're not having a whole lot of success. Not many patients are being released by the facilities or want to come here. We have a split unit. One unit will cover 1,000 beds. The other side will do 3,500. And that's about it. Any questions?
Any questions for Dario?
Nope.
I've unmuted everybody. If you're muted on your end, you'd have to unmute it yourself, and you can.
Dario, it's Michael Redlener. Just a quick question. What was the last statement that you made about 1,000 beds and 3,500 beds?
It's split into 2 units. So we can do 1,000 beds on one side and 3,500 on the other side. It was initially envisioned as split COVID positive, COVID negative, but now the whole area is COVID positive. We have 18 of the military personnel have already gone COVID, and we have another 37 under investigation. So we've given up that position, which was something that myself and health knew was going to happen anyway. So it was built on that split model. But that can also help us later on to put different types of patients inside the unit once we better resolve what we're going to be doing with it.
Thank you.
Any other questions?
Dario, this is Art Cooper. Are both Javits and the Comfort taking COVID positive patients now?
Yes, absolutely. And I know that was a rumor. Initially, the military did not want to take COVID into one. They wanted to do testing first, especially since they lost the aircraft carrier, the Roosevelt. But fairly quickly, their own staff became COVID positive. They lost 2 surgeons and 1 officer became COVID, and basically that showed that the crew was already COVID because they came here that way. So that converted everything over to COVID, Javits and the Comfort.
Okay, thank you.
Any other questions for Dario? All right, well, Dario, thank you very much. Stay safe.
Okay, I'll be here.
Great. Okay, so we're going to move towards the medical standards portion. I'm going to let David take it from here. And there's a few things that we need to discuss. I think because it's a joint call and everybody's on it, if we discuss something and it needs to be voted on by REMAC, we'll have that vote right away rather than wait and have a second discussion for the for the REMAC portion of it. So we'll kind of try to merge things a little bit. But I'll let David start.
Okay, very good. Thank you. I really want to run through a couple of mundane stuff that have been pushed off for a while because of the situation, and we want to catch up. We'll just quickly run through the regular agenda. Marie, is there anything on the correspondence report that we need to bring up?
I think the biggest correspondence is the document from the state, but we'll talk about that later.
Yeah, let's leave that. That's something that I suggest we leave for the end. I suggest I would go through everything else before that. CNC, Paul, is there anything that we need to report?
Yeah, so basically CNC's been on hiatus since everything hit, but there have been a couple of issues that have come up. I think for the people on the phone, it's important to know. We have had certification questions regarding people who are expiring, not expiring. There's a lot of back and forth between the state. We've cut to try and lay low, postponing all the exams for social distancing questions, obviously, and we extended cards. But for those people who want to get back in, it does have, lost my video, I'm frozen. There I am. If people have a card and want to get back in or expired, basically agency sponsorship or medical director sponsorship is going to be the key. We have had a couple of people try and loophole their way in, people who were out of the system who want to just use this as a way to get back in. We're trying to avoid that. But there are legitimate people who want to volunteer for the region, who want to get back, to just have them reach out to Marie, Kevin, Ward, myself. But the threshold is going to be essentially agency sponsorship.
Joe, at the time we were discussing about how we're gonna possibly remotely credential people who want to come into this
So
system.
what Paul and I spoke earlier today, and what we've done is we are going to allow, Kevin is going to obviously have to work with us on this, but we are going to set up a single testing site for people who are certified in New York State but are not regionally credentialed with REMAC cards. We will have a single testing location that will be, 6 feet separation in every which way. That hopefully will have a test next week for people who are state credentialed but not credentialed by the region. So that has been set up. We do have a date and a time. We just have to see the exact specifications of how many people we can accommodate, and then we'll run that exam.
Do we know what the location is? Do we have a location?
At Methodist on the 29th from 5 to 8. Assuming that Kevin can do it, because
Yeah.
to proctor.
Hi, Dr. Shanker. It's Kevin Ward.
Oh, great. Hey, Kevin.
Hi, I'm sorry. I missed roll call. I'm sorry. So we should be able to accommodate an exam for next week. The way I'm going to start it is I'll find out who was supposed to take their original exam in March, the exam that got canceled, and they'll get, priority.
Right.
And then we have rooms at Methodist, and we also do have rooms at the Academy if need be.
Great. So we just need to ensure that the space can be used and has 6 feet of separation in every which direction in a safe way. There'll be no waiting outside. You'll have to come over to the room, and as soon as you're done, you'll have to leave the facility, and so on. So that's what we're looking to do. It's a matter of how many people we can accommodate at any one time, and we'll go from there.
Excellent. Thank you. The next, Paul, thank you very much. The next couple of things that we want to discuss. Joe, I don't know if you can pull up the document, the TOR document.
Based off the ability to share his screen, I think.
No, it's not. We're not going. No, wait. We're not doing the protocols yet. I just want to go through the TOR document.
Oh, I have it.
Let Marie send it out on Friday. Want me to put that up, or you got it?
Okay.
Joe, I made you the host, so can you put that up?
No problem. I'll put it up.
Thanks.
All right. David, you just want to talk about the meeting that happened?
Yes. So there was there were long ongoing efforts regarding updating the 2009 REMAC Termination of Resuscitation Guidelines. You should have both the 2009 version and the version, the updated version that we want to bring for approval now. These are very conservative, non-COVID guidelines for the online medical control physicians to help guide with criteria for that would indicate termination of resuscitation in the field and not transporting these patients. We had a very group of people following the last REMAC. We had a meeting where we discussed the proposed document. We had a lot of people contribute to the discussion. Peter Wire was very kind to do an extensive literature search, which was supportive of these TOR guidelines, and we came up with a document which was distributed along with the meeting agenda for today, and you should have all had it, and hopefully Joe will be able to pull it up and we can go through it quickly. And it is on purpose. It is very conservative. And again, this is not for COVID. This has nothing to do with our current crisis. It's just a document that's long due and has to be finalized.
Okay, so I'm going to start with, I have this is the TOR from 2009.
Good.
Start with
So
that.
let's start with that. Okay, very good. Let's just scroll down.
Gotta move things out of the way here.
Okay, so I can read this out loud for everyone, or everyone can read it on their own. Patients in cardiac arrest may be considered for pre-hospital termination of resuscitation in conjunction with the online medical control physician when all of the following criteria are met. Patient characteristics, patient age of 18 years or older, no evidence of hypothermia, and the resuscitation components, at least 30 minutes of EMS resuscitation, including at least 20 minutes of ALS resuscitation, effective airway management, non-shockable rhythm, i.e. PA or systole at time of termination, no ROSC at time of termination. Important exceptions to TOR guidelines. Resuscitation attempts should be immediately terminated upon presentation of a valid DNR. TOR criteria do not need to be met to halt resuscitation when patient's DNR status is identified. The following DNR orders may be accepted by the pre-hospital providers. Other DNR orders cannot be honored in the pre-hospital setting. And we all know this, right? It's the out-of-hospital DNR form of New York State and the MOLST. And if you're in a medical facility, then the physician DNR order in the chart. So that's the that's the current 2009 document.
All right, I'm going to share the new one. Just 1 second. This one.
Somehow the screen shows only half the page.
I'm gonna just have to fix that. Give me 1 second. I gotta move it. All right, here we go. Okay, you should see it now.
Very good. Excellent. So the New York City REMAC has issued termination of resuscitation guidelines to assist online medical control physicians in identifying patients in cardiac arrest that may be considered for pre-hospital termination of resuscitation. This guideline is based on recommendations of the American Heart Association for out-of-hospital cardiac arrest, as well as additional studies that further delineate duration of resuscitative efforts and its relationship to neurological and overall hospital outcome, as well as application of TOR guidelines in the pre-hospital setting. The guidelines, this guideline is for EMS personnel, OMC physicians, and EMS agency medical directors to aid in standardization of termination of resuscitation in the pre-hospital setting. This guideline does not replace or override the clinical judgment of the OMC physician when determining pre-hospital TOR. And then the bottom of this page has all the references. And here's the protocol itself, the guideline itself. Termination of resuscitation shall be considered for cardiac arrest with all of the following criteria: age greater than 18, arrest etiology is non-traumatic and is not due to any of the following: drowning, hypothermia, suspected pregnancy, lightning injury, electrocution, suspected overdose, hanging, asphyxia. Unwitnessed arrest without bystander CPR, at least 30 minutes of EMS resuscitation time, including at least ALS resuscitative care of 20 minutes. No return of spontaneous circulation during resuscitation at any time. No defibrillation is performed during resuscitation at any time. Rhythm remains asystole or PEA with a rate less than 40 throughout resuscitation. Arrest does not take place in a public area. Family members present, if present, are willing to accept the decision to terminate. Pretty straightforward, very conservative. We would all terminate these resuscitations. It's clear. And that was the consensus of the group that met and produced this document. Any discussions?
So only ALS can pronounce?
Well, this is again for non-COVID regular operations. we would assume that that ALS would come on scene and join the resuscitation. Even if ALS starts the resuscitation, we're a resource-rich region in regular operation times, and following ALS intervention, if no success, then we can terminate.
You're right, sorry, I had to get my head out of COVID.
Yeah.
Is this going to still require telemetry consultation, or is this for providers to be able to terminate without
Absolutely. No. Non-emergency, non-COVID, non-crisis will still require telemetry contact.
All right, so two things. First of all, Robert Ackerman, you have your hand up, so I'll let you go first, and then I will clarify something. Go ahead, Robert.
Sure. Are any of these exclusions? So if a family member is not willing to accept, that you would not pronounce? I mean, how many times do we have in a Sicily where the family's in denial?
Again, please understand, this is not COVID related. This is something that is an update to our termination of resuscitation guidelines, which have been in place for 10 years. The biggest reason for this is to match up with the most recent literature. And in these conversations, it's still a conversation with medical control. Nothing changes with that. You call medical control, you have a conversation with a physician, and you'll make the decision that you made a month ago. It won't make any difference. Does that answer your question, Robert?
I suppose. I just want to know if any of these criteria, if the opposite exists, is not a criteria for the doctor to pronounce.
Well, that will again be a discussion with the online medical control physician to decide whether he wants to terminate or not. This is, again, none of these guidelines none of these criteria are here to override the telemetry physician. They're to help the telemetry physician make the decision.
Thank you.
Any other questions about this before I stop sharing this document?
Hey, Joe.
Yeah, go ahead.
Is this like a best practices thing?
I'm sorry?
Is this like a best practices?
It is a best practices guideline. It's predominantly for online medical control, and more so than for the field. The field is getting this information to know what's going on in online medical control, and to know what the most recent suggestions are. But the reality is this is mostly for the physicians to say, this is when you should be considering terminating a resuscitation.
So, all right, that's cool. That's great. I appreciate that.
Okay. All right, I'm going to stop sharing this document. What we'll do now is we'll have a roll call to vote on this new termination resuscitation guidelines. So Marie, you need to use the, let's finish the discussion. But once we finish the discussion is open to anyone from medical standards and REMAC. The voting will be just the REMAC members, though, to save us 2 votes. So is that all right with everybody? Does anybody have any questions about this? All right, hearing none, Marie, if you could go through the REMAC list, we'll vote on these termination guidelines as an
Joe, real quick, what would be the implementation date on this?
We can determine, we can decide whatever we think is appropriate. This can go out as honestly, I think that if we send it out now, it will probably lead to more confusion. But I think that once it's voted on and approved, it could probably go to online medical control facilities right away. And once things start to get a little bit more stable, send it out to the entire region.
I would suggest if we could use this as when we end the current COVID cardiac arrest standards, that it reverts back to this new version instead of the old version.
Yes, so that's, once this is approved, this will become the new standard for the termination of resuscitation guidelines. As far as the crisis standard of care and the standard of care that we're using, well, we're going to have a little more discussion about that because there's, I I think, too standard in the region right now, which we don't like to do. But yes, I agree with you that after COVID, this is what we should go back to.
Joe, this is Art Cooper. Quick question. Can you or David or somebody highlight the differences between this currently proposed protocol and the existing one? Thank you.
Sure, David.
I just I don't have it.
If you want, I can do it.
Yeah, please, if you can, because I don't have it up on my.
The patient characteristics of greater than 18 is the same for both. In the original one, there is no evidence of hypothermia. Here we talk about drowning, hypothermia, suspected pregnancy, lightning electrocution, suspected overdose, and hanging or asphyxia as arrest etiologies that would not fall under the resuscitation protocol. For the resuscitation components, unwitnessed arrest without bystander CPR is new. That was not in the original. The resuscitation time is the same. No ROSC is in the new protocol, was not in the old one. No defibrillation performed at any time is in the new one. It was not in the old one. The rhythm remains asystole. It's not in a public place. Family members are willing to accept the termination decision is in the new version. What's removed from the new version that was in the old one is effective airway management, which is not in the new version. So in the new version, regardless of effective airway management, if you've been resuscitating for a significant amount of time, you would still terminate the resuscitation, which I think makes sense because it's more of a time factor than anything else.
Okay, just one comment. I made this comment, I believe, 2 meetings ago. I'm still not entirely clear why blunt traumatic cardiac arrest is not on the list of possibilities to terminate. I hate to see patients in blunt traumatic arrest who we know have dismal prognosis transported to the nearest hospital, lights and sirens, with the attendant risks thereof. I'll ask Bob Winchell how he feels about it, since he's on the call as well. I'll leave it obviously to the group to decide what to do, but I've never understood why that was not really included in the protocol. Thank you.
Yeah, so I'd echo Art's comments as well. I'm not being involved with the history of the development of the protocol, but it seems that's as good a reason as any to not resuscitate somebody who's not going to come back.
Joe, it's Ben Zabar. I would suggest that I think this protocol makes a lot of sense for when to stop resuscitations. I know with COVID, we're going to talk a little bit about when not to start resuscitations, but I think it would make a lot of sense to have a different, separate trauma guideline, because I know there are some guidelines out there about when not to start resuscitation in trauma, blunt trauma with asystole or whatever. So I think to Art's point, like, it'd be great to have a guideline. It might be good to keep that separate from this termination effort.
So again, I think that we have to kind of look at 2 things. We're right now in a kind of a mode where we're dealing with crisis stuff as well as non-crisis stuff. I think that not resuscitating a blunt trauma is totally appropriate, and maybe it should be something that's worked into the traumatic arrest protocol rather than into termination of resuscitation guidelines. So I think that that's something we can look at separately. I agree with Bob and with Art that resuscitating a blunt trauma is probably a mistake and shouldn't be done. But I don't know if it should be in this termination of resuscitation guidelines rather than in the actual protocol for traumatic cardiac arrest.
Hey, Joe, it's Doug. Can I jump in for a minute?
Sure.
Thank you. So these guidelines were based on HA and other evidence-based literature for non-traumatic arrest. So we, and I think Art and Dr. Winchell, we've brought this up at RTAC a few times, talking about not resuscitating blunt cardiac arrest with no vital signs unseen. even started having discussion about penetrating trauma. But I think if we can take that back to RTAC and then bring forth something to the next REMAC meeting, that would probably be best. But again, these guidelines were based on non-traumatic arrest and evidence-based literature, not regarding trauma at all.
Sure, but again, it all depends. If we want to put this into a separate trauma pile, I think that's fine. I have no doubt whatsoever you'll find 100% agreement within the RTAC group for this sort of thing. But it could probably also be fit into your current general approach. It really, I think it's just a matter of style.
Yeah, I agree. I think we're having two conversations about two different things right now. I see two hands up, though, Matt Friedman and then Peter Wire. So Matt, you go first.
I'm unclear about this family role in this current termination or resuscitation guidelines. I'm not sure what a family role would hope to offer. We know that they're not going to be making rational decisions. I think it could only confuse the crews. I think we should move that line completely. I can't imagine there's any real benefit from it.
Okay. Does anybody else want to agree with that, disagree with that? Anybody have any opinions about that?
I agree. Can I add to confusion?
This is Dario. I agree with that. I think we should remove it.
Yeah, I agree with that also, because I don't think it was on any of our previous protocols.
Okay, Peter, you had your hand up, so I'll let you go here.
Just to reinforce the notion that the trauma, I don't think anyone's disagreeing with what Art, in terms of decision making, but these guidelines, the way you have formulated them, have been validated quite successfully in multiple validation trials. So I think it's purer to keep this as a non-trauma protocol and to deal with the trauma issues separately, which we might well do here.
Hello?
Okay.
I'm on a conference
I
call.
agree with you, Peter. Paul, you have your hand up.
Give me like half an hour.
I think the people who brought it for a reason, and I support it as a guidelines document or something like that. I think we should try and avoid turning it into something it's not, because it clearly has worth to the people who spent a lot of time on it. And I support Peter's comment about it being a non-traumatic entity, and I think we should move forward on either putting it forth or not putting it forth, rather than trying to modify it.
I hear you. Thank you, DJ Pauly. All right, Yoni, you have your hand up.
Yeah, I was just going to say that even though it lives in that document, that last line about the family being okay with that, I think providers probably are going to be less inclined even call for termination if they realize that that's on the table to family, if they're unaccepting of dealing with a field termination. So I don't know if it needs to live in that document or not, that last line.
Well, I think that my concern with the last line is it doesn't seem very evidence-based. I don't think that there's any scientific evidence between the family member feelings and whether or not you should terminate a resuscitation. I think it plays a role when you're talking to the online medical control physician to say, Doc, I think I'm going to get beat if I don't resuscitate this person. And that's something that should be a conversation with the physician, but I don't know if that should be in the criteria, because it's not, there's no evidence behind the family members being present or not present affecting a success of the resuscitation.
Okay.
Okay.
Cool. So,
does everybody okay with removing that last line then? The last bullet, which is family members, if present, are willing to accept the decision to terminate?
Yeah, remove it.
Yes,
Remove it.
So Marie, we're gonna do that roll call for REMAC members for the termination resuscitation guidelines minus this last line, which is family members, if present, are willing to accept the decision to terminate.
Okay.
Joe, this is Art Cooper. Just one last comment here. If we're going to not include the blunt traumatic arrest in the list, then I agree with others that this needs to be labeled non-traumatic cardiac arrest as a protocol name.
It's not a protocol. This is guidelines for the online medical control physicians.
Whatever you want to call it, it should be labeled as non-traumatic cardiac.
It's in there, Art. It's already in there.
It's already listed. It's already there.
Okay. As long as it's non-traumatic, that's fine. Thank you.
Thank you. All right, Marie, let's go through.
Okay, I'm just putting these notes in. So it's non-traumatic cardiac arrest, and we're removing the last line, the last bullet regarding patient.
Marie, I believe non-traumatic arrest is already in the document. The
Okay.
only thing,
Marie, I'm going to take out the last line and send it to you. Everything else is there.
Okay. Okay, so here we go. Please answer in favor, oppose, or abstain. Robert Winchell? Robert Winchell?
Sorry, couldn't find the mute button. In favor.
Okay. Joe Schenker?
In favor.
Nick Alexandru?
In favor.
Christopher Graciano?
In favor.
Kevin Munjal?
Yes.
Cindy Vasilios?
In favor.
Dario Gonzalez?
In favor.
Glenn Seda?
Yes, in favor.
Bradley Kaufman?
In favor.
Doug Isaacs?
In favor.
Nathan Reisman?
In favor.
Jeffrey Rabridge?
In favor.
Reed Caldwell?
In favor.
Lewis Marshall? Michael Redlener?
In favor.
Wally Carter? Matthew Fink? Laura Ivacoli?
In favor.
Peter Wire?
Yes.
Paul Barbara?
Yes, in favor.
David Benelli?
affirmative.
Okay. Tim Stiles?
In favor.
Mark Cantor?
In favor.
Joseph Bove?
Yes.
William Fisher? Robert Krupe?
In favor.
Jessica Van Voorhees? Art Cooper?
Yes, in favor.
Okay, the motion passes.
Okay, great.
Excellent.
David.
Okay, so what we need to move forward next is to discuss the new protocols that were kind of put on hold because of the current crisis. The first, so there are a couple of things that we need to go through. There are there were a number of typos in the protocols that were sent to the state and were approved, and those need to be corrected and changed. And there are a couple of
they're not typos. These are changes to the
No, Joe.
protocol.
I'm the in the
Typos don't need
protocols.
to go to the state. That's what I'm telling you.
Oh, okay. So in the protocols, there are a couple of typos that need to be corrected that have been these some spelling typos and unit typos that need to be corrected, and then there are a couple of more substantial changes that need to be changed in the protocols to in order for them to read what we were meaning during the when these protocols were written. I will let Ben Zeba run through this, but before that, Joe, I know that there were some questions about the date of postponement. To what date were the protocols postponed, the implementation, so everyone will be on the same page.
So January 1st is the date of implementation for the new protocols. We voted on that 2 meetings ago. We have to send a letter up to the state to advise them of such. that will happen this week. These changes will have to go back to the state for a vote, and they will not go into effect January 1st, but will have to go at a later date, either July or January 2021, 2022, depending on when we get it approved by the state.
Joe, I have a question. It's Ben. I guess my question is, if these changes were approved here and were approved by the CMAC either in the spring or in the late summer, why couldn't they potentially start January 2021?
Because they're going to but the state is going to come back to us and say, you guys haven't begun the training on the stuff that was supposed to be July 1st because of COVID, and now you're going to have to revamp your training with new material. We have to get started on training, and I don't know if we're going to get an opportunity to get this approved before we have to start training. So we have to start training on something at some point.
Right. No, I agree. I mean, I can say for the fire department, these changes, we definitely could make these changes to the training material very quickly. And actually, most of these changes in the current training material are already sort of there, because we had to explain to people that, where it says, milligrams per kilogram for dextrose, that was an error. It really means grams. So most of these changes are already ready.
That we can just do, Ben. The only thing we can't change is a change of intent. So if the protocol says give 1, 2, 3 EPIs and we're giving 2, we can't make that change without the state. To say that it's grams and not milligrams or milligrams and not grams, you can definitely do without going to the state. We can do that today.
No, I agree it should go to the state. I'm just suggesting that if the state approves this, before September 1st, I think it'd be reasonable to have these changes included in the January protocols. That's my suggestion.
We can attempt it, but I don't know that that's going to happen.
Okay.
But we can try. We can send it
Okay,
up
fair enough.
through.
So why don't we bring up the changes, and I'm gonna let Ben run through them.
Okay, I'm going to go from sort of least controversial to most controversial.
Ben, let's let Joe pull up the or Pesach pull up the
no, you sent it to
document.
Just to go from least controversial to most controversial. So the first one to look at is the non-traumatic cardiac arrest, severe bradycardia for pediatrics.
Okay, can we expand this document somehow so we don't have all the background and just the document itself on the screen, please?
Give me a second.
Can we also vote on each change as we go?
Yeah,
Sure, I have it up on the screen already.
Okay, Pesach, but we need somehow just to see a bigger document of this. Yeah.
All right, so Pesach, if you can go down to the medical control options for the non-traumatic cardiac arrest, severe bradycardia peds. Look at that one.
No, this is not it, Pesach.
Yeah, keep going down. He's getting there.
Yeah, this is the entire doc. I'm gonna go to, I thought he was starting at the top. So which one do you want?
Guys, hold on. Paul, you have a question?
When we get to the part,
non-traumatic cardiac arrest, severe bradycardia, pediatric.
Joe, I'll raise my hand when I see the part that I need a question about.
Okay.
Paul, you lost your background. The iceberg is not melted.
I had to switch computers, and this one doesn't.
So this, I believe the intent was basically as a typo. This is changing the dextrose dosing to be consistent with everything else to 0.5 grams per kilogram. But it would accidentally said milligrams per kilogram.
That's a typo. That doesn't. That's good.
I know. I think we were told it was too big a that was potentially a change, so that's why it was being brought forward. There is and then there is a similar. I'm just looking for the other one. There's the same thing in seizures pediatric, the same typo. Do we have to show that, or is that okay?
That's fine.
Okay. Pesach, can you go to shock sepsis peds?
Joe, this is Art Cooper. I would certainly consider those typos. Thank you.
Thank you.
And this, wait, you just had it. Yeah, same thing in shock sepsis peds. This is synchronized cardioversion. It says 0.5 milligrams. It's clearly 0.5 to 1 joules per kg?
That is
Yes, clearly a typo.
Okay. Now, Pesach, now this is a more substantial correction. Pesach, can you go to adult anaphylaxis, please? All right, so while he's doing that, I'll just say the background is...
Wait, Ben.
Yes, yes.
Are we done with the typos at this point?
I think, yes, it's up to you if you want to vote on those or...
Okay, yes.
No.
Okay, so
we
do we need to
vote on the
No.
typos?
Typos don't need a
Okay.
vote.
They're
Okay,
fine.
perfect.
We just need to vote on the substantive changes. That's what I'm trying to tell you guys.
Okay, so for
Very
the
good.
record, all the typos that we just went through, I can document as approved for correction.
Yes.
Okay.
Okay. So for anaphylaxis, and this was discussed at the last in-person protocol meeting, that what was presented to the state, and I believe the intent is that the patient in between CFR, BLS, and ALS can get 2 doses of epinephrine under standing orders in whatever combination, but CFR can only give 1 dose. And so we attempted to sort of wordsmith this to make that clearer. So we changed, can you go down to number 10 in EMT? So this is because there is some confusion about whether the CFR epidose counted for EMTs or not. So basically the EMTs would give their first dose of epinephrine in step 8. And step 10 says the EMTs can give a second dose of epinephrine if needed and if available. And it makes clear max total 2 doses under staying orders, including the epinephrine given by CFR. And then can you go down to the paramedic, Pesach? I just want to show all the changes in this and then we can discuss it. Pesach, go up. Where is it?
There was no change in the paramedic section.
Okay.
The changes in the medical control options here.
Right. So the idea is that the paramedics would be able to give their 2 doses of standing orders under the EMT section, steps 8 and 10. And then the medical control option was changed for EMTs to make clear that that is calling for additional doses beyond the 2 standing orders. I don't know if there's any discussion or comments about this.
I think it makes sense. It clarifies our initial intent when writing this protocol.
Oh, by the way, Pesach, can you go down to the key points, number 7? We also added in a key point to make very clear patients in anaphylaxis may receive 2 doses total of epinephrine between CFR, BLS, and ALS under standing orders.
Does anybody have any questions about this?
Of course, if anyone wants to give a 3rd dose, then we can always contact online medical control for their approval for that.
Does anybody have any questions?
I have a question. I don't know if you can hear me, but I have a question.
Yeah.
Hello?
Yes. Yeah. Who is that?
Oh, I'm sorry. It's Josh. So in training, we're going to be including the self-administered dose under the CFR. And this kind of says that if the CFR did not administer it, then does the self-administered dose count? The second question brought up about what happens if the patient self-administers epinephrine?
Ben?
I don't know. I mean, I think that's it's a little confusing because I think there are some medications like aspirin where sort of what's given prior to arrival we feel like probably counts. There are other things like naloxone where it seems like the protocol says if you think they need it, you give it. Our current protocol doesn't, I don't think, specify whether that prior to arrival dose counts. So I don't think this protocol changes that from our current protocol, but I don't know what the group thinks about that.
Yeah. Hi, this is Nick. From discussions up at the state, that was never brought up as a discussion point. Clearly, only if the CFRs can assist a patient with their own medicines, but nothing about the medicine specifically being theirs and counting as 1 dose.
Okay. So I suggest we should just leave it as is.
For clarification's sake.
This is Pesach.
You can say,
Okay.
Are we counting the
account details, transponder and vehicle options, take a survey, or more options?
Okay, guys, please mute your phones if you're not talking.
Wait,
We're
maybe
getting,
we should take a survey.
GPS.
Yeah,
Yeah.
more options.
Dave, it's Pesach. Can I say something?
Yes, go ahead.
So I think just in the field, the way I've been taught and the way the practice that I've seen is that we generally count previously administered doses that were given by a healthcare professional so they can be verified that they were administered correctly. And we don't typically count previously taken doses by the patient that were self-administered as into the account of how much we're going to give based on our protocols. If a patient tells me that they took aspirin when they called 911, I'm still giving that patient my protocol dose of aspirin if I feel it's warranted. Versus if a doctor's office calls for a patient having chest pain and he tells me I gave the patient aspirin, I'm going to take that as a prior administered dose and reduce that from the dose I would have given. And I think we can say the same thing if a patient self-administers that we don't know if it was administered properly and what the effect is, if it was expired or not. I mean, we can look at it, but if it's self-administered, I don't think we ever use that as a reduction to our protocol dose in the past.
Yeah, I agree. I think that makes sense. Okay.
Can I speak, Dave?
No, there's a
yes.
big difference between prescribed and over the counter, but you know.
No.
Yes, go ahead. Who wanted to speak?
This
I'm
is
sorry.
Paul. David?
Go ahead, Paul.
I totally disagree. If we're going to say, I mean, people who are in refractory anaphylaxis get an epi drip in the hospital. We've put people on epi drips. If we're going to limit the amount of epi, you can't have it both ways. We're either going to limit the amount of epi and say 2 doses between CFR, BLS, ALS, and bystander, which epi is in the community and readily available, and people are taught to give it. So either we cap the dose and we count the potential for bystander epi, or we don't. I think that it's got to be one way or the other. If you're going to cap it, you should say they shouldn't get more, because we're saying it's so important they don't get more than 2. It's very important medically. So the reality is why are we not counting the one that's delivered by an injector? It's not did they do a nasal Narcan the right way? This is an auto injector. You know, this is supposed to be foolproof. So the medicine has to be the medicine. Either 2 is too many, or 3 is too many. But to say that one doesn't count because it wasn't given by a provider, then we shouldn't even say that it works. That's my point.
I think the problem, Paul, is sometimes people are very hesitant with their auto injectors and don't give it appropriately, and you can't really get it done right.
Brad, your phone needs to be muted.
Then I say leave it to judgment and pull 7 out.
Oh,
We have it both. We can't have it both ways. You can't say 2 is the max and expect people to not count the one that's given by a bystander. And an extra 162 of aspirin isn't a big deal. But we're saying 2 is the most we want given in the pre-hospital setting, except when it's 3. When it's given
Just
by
to
a
interrupt, this is Nick again. Up at the state level, the conversation was really around 2 doses by CFR. We got around it a little bit by saying that we have dual responses and our EMTs will come on scene and give a second dose. But that discussion specifically by a bystander or the patient taking their own medication was not brought up. And I suggest we leave it the way it is because of the fact that it will change the meaning of what the state actually wanted us to do.
And by the way, I just took another look back at the state protocol. The state BLS protocol doesn't mention the bystander dose. So I think it'd be good to leave it this way.
Morty, do they cap the dose?
That's Ben.
It's
Ben,
Ben, sorry.
Ben, do they cap the dose?
Well, it says that if available and trained, give the patient epinephrine. It doesn't talk about what was given prior to your arrival.
7.
No, it's 2 doses and then call online medical control for more. But the thing is that our CFRs don't carry 2 doses. But our dual response that other regions don't have is able to provide for a second dose.
Right, but the
protocol was approved.
Right, the state makes no assumption in their protocol as to what may or may not have happened prior to our arrival.
Right.
I pull my whole point. We're talking about insanity. I apologize. I withdraw my statement of good medical judgment.
I just think it's easier not to alter the state protocol on this point.
Stop for a second. Excuse me. Just stop for a second. We're not going to let this deteriorate into a conversation like this. This is ridiculous. We have a lot of stuff to cover.
Exactly. I said I withdraw my point, Joe. I withdraw my point. I apologize.
Oh, stop. All right. If we need to discuss this at a protocol meeting separate from this, then we can do that. But if we want to all be on the same page, I think that the intent here was to have 2 doses by our providers, and that's what the intent was. If somebody gave it beforehand and they're still in severe distress, I don't know about you, but I would give another dose. And if we want our providers to have 2 doses without calling somebody, that's what the answer should be. So I don't want to kind of jump on everybody, but I think that if we're going to discuss this further, it should go to a protocol discussion. Please don't put that up. Please don't. I don't want to. We're not talking about the state one. They already approved ours.
Yeah, Tessa, please don't.
Joe,
please.
Bob Kirby?
Yeah, Bob.
I mean, can we just leave it alone, but take Paul's suggestion, leave out 7? Because that can be confusing. Like if we're saying we can't give more than 2 doses, because what if the provider, is aware, that a dose was given prior to arrival? They may construe that to mean that they can only give 1 dose.
Well, they can only give 2 doses under standing orders. That's all that number 7 says.
That's exactly it. I think it's simple and straight enough.
I'm sorry, the state protocol wasn't supposed to go up. Do you do the REMAC protocol now?
So listen, the answer is very simple. If we want to discuss this further, we can do that at a separate protocol meeting. If we're going to continue this conversation right now, we need to bring forth something that can be voted on and not have a 20-minute discussion about it.
It's been, I think we should just vote unless people feel strongly about sending it back.
Okay, I agree. If there's need for any further discussion, we're going to move this to the next protocol meeting. Whenever
Yes,
Marty.
Dr. Marty, just a clerical point here. Instead of writing a 3rd dose, maybe we can write additional doses rather than limiting it to 1 more.
Where do you see 3rd dose?
In the medical control option.
It says additional dose. It doesn't say 3rd.
Oh, I apologize. I'm sorry.
That's all right. If people want to vote on it, I would show the pediatric as well because it's basically the same. If you don't mind, Dave.
Yeah, go ahead.
Okay, so you go down to pediatric. So pediatric, the EMT is exactly the same. And 10, Pesach, keep going down. Keep going down. There's the medical control option. It's the same for 1. Under the paramedic, there was an error here where it says patients remain in shock. See the pediatric pressors. There is no pediatric pressor protocol, so we want to remove that 2C because that was an error. And then Pesach, keep going down.
Yeah, that was my error.
That's fine.
The protocol was made by copying the.
Keep going down. Go down. So there's also the same key point 7. So Dave, which is I think 8 because there was some other point. So Dave, unless people feel strongly about saying the protocol, I would suggest voting on these 2 together.
Okay.
And one more
Any discussion?
Protocol, just while here. There's just a typo here in this protocol, I believe. Right here, you can really, there's an extra slash. It's a typo. It's remove that slash.
Okay, whatever's a typo, I don't think there's a problem.
I just wanted to.
Yeah.
Hey,
okay.
Sean Graves.
Any discussion?
Dr. Kirby, Sean Graves.
Hey, go ahead, Sean.
Yeah, so I sort of echo a lot of the sentiment about removing that last part. I think from a provider standpoint, I think removing 7 and 8 respectively from the adult and pediatric protocol makes it an easier flow. I don't think it needs to be redundant. It's self-explanatory in the way that the protocol flows.
I think I tend to disagree. I think number 7 clarifies and makes it clear to everyone, to understand what we want this protocol to deliver, and it directs and it makes it very clear. It spells out what was the intention of this protocol. Any further discussion?
Okay.
Okay, hearing not, Joe, let's please vote on this.
So Marie, we're going to do another roll call to approve this epinephrine change under adult and pediatric protocols. This will have to go to the state for approval at the state as well. Marie, you there?
Are you talking to me?
Yeah.
Are we voting on each protocol separately?
No, we're voting on, there's only one thing we're voting on right now, and that is the what is this? Anaphylaxis protocol for adult and pediatrics to make the changes to 2 total doses under standing order and then additional with medical control.
I'm just writing down anaphylaxis for adult and peds.
Perfect.
And then we can do the specifics
That's
later.
Fine. Okay, go ahead.
Okay. Okay, just give me 1 second. Okay. In favor, oppose, or abstain? Robert Winchell?
In favor.
Shoot. Stupid computer. Okay.
Thought you didn't like my vote.
No, your vote was fine. Computer's a pain. Joe Schenker?
In favor.
Nick Alexandru?
Yes, in favor.
Christopher Graciano?
In favor.
Kevin Munjal?
In favor.
Was that in favor?
Yeah.
Cindy Vasilios?
In favor.
Dario Gonzalez? Uh-oh. Dr. Gonzalez is not there. Okay. Glenda Seda?
No,
In favor.
Okay. Glenda Seda?
In favor.
Bradley Kaufman?
In favor.
Doug Isaacs?
In favor.
Nathan Reisman? Nathan?
In favor. Can you hear me?
Okay. Jeffrey Rabrich?
In favor.
Reed Caldwell?
In favor.
Lewis Marshall? Michael Redlener?
In favor.
Okay. Laura Ivacoli?
In favor.
Peter Wire?
Yes.
Paul Barbara?
Opposed.
Opposed? Okay. Come on, computer. David Benelli? David
In favor.
Benelli?
In favor.
Okay. Tim Stiles?
In favor.
Mark Cantor?
In favor.
Joseph Bove? Joseph Bove?
I think he's.
I heard a cough. That's all I heard. Okay. William Fisher? Robert Krupe?
In favor.
Arthur Cooper? Arthur Cooper?
In favor. In favor.
Okay, it carries. The motion carries.
Thank you. All right.
Okay. The last thing, just quickly, and people may want to refer this back to protocol. Pesach, are you there? Pesach. Pesach, can you hear me? Okay.
Yeah, I hear you. I was just on mute.
That's all
Sorry.
right. So on the state protocol, basically, there's a general approach to cardiac arrest, which includes the H's and T's. And I just looked. The ACLS, card is similar. It's not just H's and T's for VFib, VTAC. For PEA asystole, it basically says if you suspect a pneumothorax, you can decompress it. And I realized I think it was sort of a possible error that was only in PA asystole and it wasn't here. I know it's more likely in PA asystole, but the protocol reads right now that if you think there's a tension pneumo, but the person's in VFib, you're not allowed to decompress. If people feel like, yeah, we should just have it be the same in both, we can change it now. If people think it's going to be discussion, we can send it back to protocol.
Well, two things. First of all, I don't think it says that you cannot do it. I think that it's specified in PEA asystole because of the higher likelihood in those cases. What I do think, though, is that if we want to discuss this, it should be done at protocol. There's two people with their hands up, though, Yoni Klein and Paul Barbara. So, Yoni, you go first.
Thank you. I think we brought this up at the last time we met, and the reason being is that VFib and pulsus VTAC are not associated with pneumothoraces routinely, according to AHA, and we had discussed about the removal of point 2, which refers to Appendix O, as it's not clinically warranted. I don't think it excludes providers who identify patients with pneumothorax, but I don't think that it should live in this protocol.
Well, I think number 2 is an addition.
Yoni, I'm not,
it doesn't exist right now.
Yes. And to Yodi's point, I think, and maybe this is for protocol, that we need to create a separate protocol, but currently, other than arrest and trauma, chest trauma, there's not a protocol that sort of says, go ahead and do the decompression. So that's, the issue, that there's nowhere that says they can do it. But
it doesn't say they can't. But Paul, go ahead.
I fully support this going back to protocol and I can't wait to see the literature citations, and I'd like to know the incidence of tension pneumothoraces and the required decompressions in our region.
Okay. I tend to agree with Paul. I don't think that there's any emergent reason to do this right now. I think that this is a larger discussion. I know that, Brad had some feelings about the literature supporting it as well when this first came up. I think this should be discussed in greater detail rather than in 5 minutes on this call.
Okay, let's send it back.
Very good.
That's it. That's all I have.
Perfect.
Okay. Thank you very much, Ben and Pesach. I think that with that, the medical standards portion of this discussion of this meeting can end.
Dave, sorry, just about to Joe's point, that I know you said there's a letter going up to the state, but if I would just remind that, so there's going to be an advisory at some point going out saying that the protocols have been pushed off for the implementation date, because as of right now, it still says July.
Well, we can't send out an advisory until the state accepts it. So
gotcha.
We know what the story is. We know that it's going to be delayed, but we wouldn't be able to send out that advisory without the state saying it's okay. Unfortunately, that's the process.
Right, because I know that I think we should just try to avoid where if the state says no, we may be sort of stuck because we can't have the fire department.
I don't see a situation how the state can say no, Ben.
I think let's jump off that bridge when we get to it, because I don't know what they're going to say, but I do know that we would have a hard time sending it out without them having approval or be able to acknowledge that we've done that.
Pesach, I think you can stop sharing your screen.
Yeah,
perfect.
Okay, so just as we're going to get into the REMAC part, I'm going to start with. So the executive committee did send out some advisories. I know you all have seen them. We sent out an advisory initially 3 weeks ago about CPR standards, where we were not going to transport asystole arrests, or not going to transport, arrests without ROSC. That met a lot of public, there's a lot of public comment and opinions on that. A press release was sent out regarding those changes. which were all in line with current evidence-based medicine. So I just wanted people to know that that went out. And obviously there was another advisory that went out on Friday night with regards to the states, which we're going to get into in a minute. But before we do that, I'd like to just pass the floor over to Michael to talk about some QA stuff from the QA committee. So Mike.
Hi, Joe. Thanks for recognizing me. So we haven't had given the current situation, we haven't had a quality assurance or quality improvement meeting in the last 2 months. But I wanted to just talk about some ideas related to how we're thinking about our care during the coronavirus pandemic. So I just wanted to bring up the suggestion or recommendation about some, kind of discussions I've been having kind of offline with a number of folks throughout the region about how we're looking at the care of our patients during this time. Some of the suggestions that have been made around looking at this care is looking at, I know there's been some public data around cardiac arrests and the number of cardiac arrests, and that's been reported. But I'm wondering, just given the protocol changes that we've had over the last couple of weeks related to, one, the viral pandemic protocol, and two, the cardiac arrest protocols, I would suggest that we think about how we look at these things as a region. So one, looking at kind of our numbers of RMA throughout the system, as well as looking at cardiac arrest transports and that type of thing. I would imagine, and I know the fire department has been, looking at the internal data around these things. So I don't want to duplicate effort, but I would put this out there for comment about what we should do as a region. So if anybody has any thoughts or ideas, there's a lot of work that's going on around the country for this. And it's obviously applicable to a lot of regions as they look forward. But, we could potentially be a leader in this as we think about the next go around and what we're looking at as we understand how the pandemic affects us. So I'd open it up for comment and guidance around what we might look at as a region in relation to the pandemic.
Okay, any comments, any discussion on what people think would be appropriate to do some quality improvement or quality assurance or quality and safety projects about with regards to COVID? All right, well, I'm glad everybody's really into quality.
How about the number of protocol changes and the impact on the providers in the field?
I like that. I think that, we made 3 significant changes to our protocols. One with regards to staffing standards, which never was implemented because we didn't need to. One is this viral pandemic, and really to see if that has affected, from the time it was implemented, if that has affected transports, not RMAs per se, but actually transport decisions. And the other question was about cardiac arrest and how that has, how the numbers have changed with regards to COVID and before. I think those are 2 really significant topics that we could probably look at. There is a question on the chat here from Robert Ackerman. Since the city has First Watch for stroke, can we use it for COVID? So Mike, do you want to try to answer that?
Listen, I think our initial intent for the First Watch tool was really, in partnership with the AHA around stroke and STEMI. I would be up for recommendations in terms of how we could reapply it to something like this. I think that they do things that First Watch has capabilities to look at, pandemics and pandemic response and what it looks like and what it does to our system. So I don't. It's probably a reasonable idea, but I think that we as a region need to decide what it is that we are interested in looking at. So so I think that that's the first discussion, and then we can kind of circle around to how we would do it.
I agree.
Hey, two quick comments. One, I think it's a great point that you brought up, Mike. For looking at the quality in cases where we don't transport, there's an inherent challenge as what exactly are we defining as our quality metrics. I think that in our ET3 quality metric proposal, there was discussion of like who would end up back in a facility in a hospital. I can't remember the time frame we decided on as a region, but maybe it was 24 hours or some longer time period. So I think it's an opportunity to try to start to gather some of that information, but there's a number of sort of technology and data collection challenges to really get a good look at that. I think within our own health systems, we might be able to do a little bit of that. And to the extent that the region can coordinate some collaboration around that, I think that'd be a great opportunity. So that's one point. The other point is we may not necessarily view it as sort of a protocol change that REMAC made, but there was also the 911 call triage process that, sorry, excuse me, that Dr. Prezant and others, the fire department implemented in partnership with some of the hospitals. So there really was a incredible array of changes that occurred in the past 2-3 months or less, I think 2 months in our EMS system. So I think there's opportunities to kind of describe that process at the high level, volume wise, but really getting down to quality. I look to others to kind of think about how best to do that and coordinate across the region, because without good data, we're just, unfortunately, we're leaving patients at home, and for the most part, we as the REMAC don't really have a good sense of what's happening to those patients, and that is a larger problem.
I agree. You have your hand up.
Yeah, hi. So I just want to touch on a couple of points. So I think that I think that it's a great great idea in terms of trying to be able to really see what an impact a pandemic like COVID has on our region, and also especially in terms of both of our operations as well as our quality of care. However, I think that we have to be careful, especially with First Watch and its relationship with AHA, just in that this is originally a project that is funded by the AHA and funded by the Helmsley project, that is originally just to kind of monitor both of our stroke and our STEMI data. It's not really so much as a surveillance tool for a pandemic. And I think that we have to be careful in that, at least right now, we're still just sort of on the starting ground in terms of getting that project aboard and getting that thing functioning, that I think that we don't want to really try to broaden and take too big of a bite of more than what we can handle right now, just in terms of kind of coordinating a lot of data collection and everything else with that. And I think that that's something that we can better discuss a little bit offline in terms of maybe some other uses that we can use for First Watch, but that needs to be a different discussion that's going to be outside of here. The second part, in terms of REMAC and sort of coordinating efforts and things like that, as many of you guys are well aware, that the fire department does do a lot of quality assurance, quality improvement work, on the 911 system, and we are doing a lot of things right now just in terms of how these protocols are impacting the 911 system. In terms of, REMAC and those other things, and that's going to be, something that we may just have to coordinate in terms of how does this impact the, the volunteer system or the non-911 system response. And that's something, again, that we can kind of discuss offline. But again, for a lot of the 911 issues, the FDNY is certainly very closely monitoring this.
Good. I mean, I think that, listen, the conversation is the same for both 911 and non-911. And, I think it would be interesting to hear kind of the experience of the fire department in general about what the the findings are and that type of thing. It would be interesting to understand that what's going on. But yeah, I mean, listen, I think that the idea is that there's a QA responsibility for the region, I think it's a really good idea to kind of figure out a way to kind of play our part in looking at the impact here. And so we can follow up offline. And what I'll do is I will send out a notice around QA meeting and really kind of hash through some ideas related to this.
And Mike, it's Ben Zaber. I would also try to figure out what the.
Ben.
Go ahead.
Wait.
Okay.
Yoni, you had your hand up. Let's go in order here.
Yeah, thank you. So I know that it would be very nice to look at these metrics and really make some data-driven decisions. The one thing I can tell you as a provider, as an end user, that's going to impact your data set is going to be the dissemination of information to the providers in the field. So right now, there's so obviously I work for the fire department, so I hear things from really three data streams. One's from the New York State Department of Health, one's from the regional council, and the third is the agency I work for. If there's not a harmonious message or timing of the release of the message, I think that skews your data. So New York State Department of Health releases this termination of resuscitation guidelines, and then the region obviously put their position statement out, and the fire department obviously put it to their members. But in that period of time from which New York State Department of Health clicked send to the time that we clarified everything to all the providers in the field, there's probably a lot of incongruency in care and following the procedure. So that data set may not be the best data set because you have different agencies practicing to different medical standards, so to speak. And it may be, if we want to have measurable data and really make it easier for the providers, is really focus more on the effective messaging and the timing of the messaging. And I think that would, A, alleviate the burden on the providers, and the second is give you a better data set to make better clinical decisions.
I think that's a very important point that you're making, and I would say that it's a related issue, like you're saying, and I think that looking at data doesn't take away the responsibility for communicating policy and procedure well, but I think looking at data can tell us if there is if there's difference in expected data, and can help to inform kind of how we do better moving forward.
Right. Yeah. So I think that there's definitely a couple of things we can look at. I think we should take it back to a QA committee where we can really hash this out. Pam, you're right. We should kind of figure out how we can use FirstNet. It was originally a certain way from the Helmsley Trust, but now that everybody has it, maybe we can use it effectively. I don't know. We'd have to really kind of offline talk about that. Ben, I cut you off, so I apologize, but you got the floor.
No, not at all. I would just think about working backwards, because normally for QI, we measure something and we do an intervention, we remeasure it. So I think what's hard is if we look and we say, hey, this was something that was not ideal a month ago, but now the situation's different. I would just try to figure out, well, what's our goal or our intervention? Because I think there's a lot of things like, terminating CPR after 20 minutes. We don't think that was going to lead to better outcomes. And if we say, hey, there was a worse survival rate during that, the question is, well, what do you do with that? So I try to figure out what is it we want to measure that we can intervene on to improve things, rather than just say, wow, we were really overwhelmed. So I just work backwards.
No, 100%. I think the goal would be to develop some sense of, a baseline expectation and benchmark for what it looks like next time. So it's a complex discussion and involves a lot of effort, but I think it's probably worthwhile.
Okay. Anything else from a quality assurance and safety perspective?
No, I think Joe, just this is kind of the starting to enter the recovery phase and get back to the things that we normally look at. So I'm excited to kind of revisit our stroke and STEMI project and get back into getting to our regional dashboard on those efforts, because that's our primary goal around that topic as well. So looking forward to working with everybody on that again.
I agree. Okay. Let me get to the last piece of agenda item, and then we'll get to new business. So this Friday, the state sent out a termination of resuscitation guideline. Not termination of resuscitation, a crisis standard of care for cardiac arrest, which was in the works for about a month before it finally was sent out. It was sent out in a very rapid fashion, probably not the most appropriate fashion. It was sent out at 5 o'clock on a Friday night, and it led to a lot of confusion in our region. There were calls and there were conversations about how this should be implemented, whether we're still in that crisis standard right now. Most people that were on the call on Sunday night at the state level did not feel that we were still in that crisis level where we would need to do something like this. And the state is working on language to kind of rewrite what they, or not rewrite, but to basically take a step back between this effective immediately at all levels to a regional approach. So we're starting to think about some language in terms of how to best approach this on a regional level. I'm thinking along the lines of, citing that this protocol is appropriate as a crisis standard of care, but at this time in our region, we are no longer in a crisis mode, or in that significant of a crisis mode, and we will continue to operate on our current cardiac arrest protocol, which is still to not transport patients in cardiac arrest that have no ROSC or no, those patients. I think we should go back to that standard, not back to the original standard or our normal standard yet. But I think we should go back to that standard where we're not transporting people who after a resuscitation are still in cardiac arrest. Perhaps that is not something we should do yet. And then start working our way back towards thinking about how we get back to our normal standards of care. So I open that up for discussion. The exact language isn't completed, but it will be shared before it gets sent out. We're working on that today and tomorrow. But any opinion, any discussion on sending out something to the region to kind of walk back what the state had done and be in line with what makes sense?
Hey, Joe, it's Glenn Asada from the fire department. Thanks for that synopsis. Luckily I was able to get on that call as well. The state asked me, and Lou Marshall did as well. And, I think the whole thing was that a month ago, I think we could have implemented this, and I think there wouldn't be any question. It would have been beneficial. But as you said, and as I think about 8 out of 13 regions were represented on that call on Sunday night, nobody actually, not maybe a few, but no one agreed that this was needed to be implemented at this point. Our volumes hit 6,200. I mean, the actual numbers were 7,111 was the highest, but with multiple calls to the same location, so that just turned out to be about 6,200. And as you know, our call volume is usually about 4,200 per day. So going to 6,200 is a 45 to 50% increase. And what was even worse for us at that time, as you all know, is that cardiac arrest went up about 8 times as many calls per day. And that's odd because I don't know if people were saying, I'm being told to stay at home, so I'm not going to go, and then just not waking up the next day. Our volumes, again, at this point have come down to a point since April 12th, we've actually been at about 4,200. And in the last 6 days, we've actually gone down to 3,155, I think, 2 days ago. So we're down now 10 to 15% call volume wise. And I think that's been reflected at the hospitals as well. I heard this earlier this morning. One of the hospitals called and said, hey, what's going on? We're not getting patients anymore. They thought EMS was not taking patients to them, but that's just what the volume's been going on. ICU beds are still pretty full, but they're more available now, to a point where I'm hearing that some of the vents in New York City are being sent up to Boston because they're having some problems and things like that. So the cardiac arrest issue still, despite our volume being down, is about 3 times higher than it normally is. And perhaps it is that people are staying home. And I think the 3 deaths that occurred over the weekend at the City Quarantine Hotel in Midtown Manhattan may indicate that, these people were potentially stable, sent to this quarantine place, and then just found dead in the morning.
So maybe that is what's happening, where people seem stable, but then take a turn for the worse. I don't know. But that cardiac arrest is definitely still concerning for us, but not to the point of 4 weeks ago when this was going on. And, the first thing the state said to us on that call was that it was a bad release. That was a quote, that it went out partially when it was supposed to still be in discussion. And, I told the state that this was a previous conversation right before the meeting. I told them that they were out of touch with New York City and they were very offended. But, what was going on 4 weeks ago was it's just not the same at the moment. So we're actually in a de-escalation phase where we're trying to go back to some of the things that we've been doing in the past. This 1095 Charlie of patients, following the state protocol of if you are subjectively having a fever, because we don't have thermometers for us, and the pulse ox we were able to finally get. We've been doing this for about 5 days now. And quite honestly, we're finding that in about 30% of the cases, crews, this is FDNY now, crews are either not even getting a pulse ox or under 95%, which is what the state guideline says, they're supposed to be taken, they're being left. We're looking for potential bad outcomes. And we had heard potentially of 2 bad outcome cases, but we can't track it, luckily. I don't think that's happening, but we are getting some callbacks. So ultimately, if they're going to the hospital anyway, maybe it's better to take them at the front end. But anyway, so, I know that when you guys put it out as an advisory, I had sent you an email as to why, I'm not sure why this went out like this. Was there discussion? And I think, quite frankly, your answer is correct in that this came out from the state. It looked like this is it said it's mandatory. And yet we're very comforted from our legal that the headline still said guidelines, just like the other one as well. So we were comfortable to say, if we actually continued CPR for 20 minutes, then we're actually superseding it. And quite honestly, the Post reported, the unions are all over the place saying, we don't understand why the state would even consider this, because we're supposed to be saving lives and they won't even let us touch these patients. But I got to tell you, the state put us in limbo from Friday night to Saturday afternoon as we tried to figure this out, because some of the medical directors, on this call now decided to follow the state protocol. So at that time, when I first got the call at 10 p.m. that, hey, one of the agencies is following this and just advising us, we got there, no pulse, not witness, we didn't do anything. We couldn't challenge them at that point. But once we got our mat out that Saturday afternoon, I think we're all back on the same page. And I think that having this available going forward is great. Some people were worried about a second wave of this happening again in the fall and such. Once we get to that point, we may want to pull the trigger. I think some of the language that you mentioned that they're trying to work on at the state, I think makes sense. Despite our unions going to the media saying that, they're asking us to reuse PPE and we're running out. That never occurred in our system. We came close, particularly gowns at one point, but we never ran out of PPE. And so part of this, the language in this new draft will be that, if PPE is not available, then then we really need to pull the trigger on not really resuscitating those patients that are not viable. As a matter of fact, with the numbers coming back now, we're looking at potentially, not yet, but going back to bringing potentially pulseless patients. Pam was able to advise us that about 17% of our cardiac arrest asystolic patients initially end up having a pulse. Now, the survival rate we know is very low, but so these are things that we want to look at. So right now we're doing a de-escalation. The 1095 Charlies are probably going to be changed, but we can't get back to normal yet, but we are looking at certain things to try to get back, because I think the hospitals are not overwhelmed yet. The Javits Center and such, and U.S. Comfort, great that they were there. We are hearing that, they could take 3,000 patients, 3,000 beds available, and I think we just hit 1,000, I think Terry reported earlier. So, it's great to have, and I know they're going to continue to be there. The National Ambulance Contract put 200 ambulances into the 911 system for us. The staffing standards, we were getting very concerned because we remember what happened with SARS in Toronto. 50% of the workforce went out under, and it affected them. And we know that things don't change overnight, so we need to have a plan in place. Luckily, the REMAC was able to say that, in the pandemic situation, if units can't put members out there now, we're going to have to go to that state standard instead of the regional. And luckily, I don't think we had to pull the trigger. Our, voluntary partners, thank you to everyone, because the report was that nobody ever went under 100%. As a matter of fact, most were above their number. So that was really, really helpful to us. I mean, we can't do this without everybody's assistance. So thank you. But, that's just kind of what I hate to say it, but the state's not in touch with us. And for them to, Greenberg told me that, oh, well, it took us 3 to 4 weeks to put it together. So by the time we put it out, when we were starting it, we needed it. But again, that's the out of touch piece. Nobody on that call said that they needed this right now. Right. But I think it's good to have, and the state wants to retain control, which is fine. Let them retain control, but we have to be realistic.
I agree. I think that we have to kind of use it as a tool if we need it. But I see Yadidja and Michael have their hands up. So Yadidja and then Michael. Yadidja? You gotta unmute yourself.
Yeah, I did. Okay. I understand what Glenn is saying. I understand there's a serious issue here. The only thing I wanted to comment was, and I don't want to comment, on the quality of the protocols one way or the other. Everyone's doing their best. But the day after the FIDNY sent out their advisory, their guideline, I got multiple phone calls from people saying, what should we do? The state says one thing, REMAC says a second thing, and FIDNY says, we're not listening, we're doing our thing. And medics who are on calls are now afraid that whatever they do, they're going to be written up. Okay, if they don't follow what FIDNY says, they're going to be written up. If they don't follow what REMAC says, they're going to be written up. So there's got to be coordination here. I mean, if Kevin, if the not Kevin, I mean, if this happened, then I think REMAC should have gotten on board and sent out a citywide advisory immediately saying, this is what we're going to do. But
I hear you. Here's what I would suggest, and I'm sorry to cut you off.
I'm done.
I think that the challenge, and I see Nathan has his hand up, and so does Michael. So we're going to go Michael and then Nathan. The challenge is to send out more information that we're then going to have to change as soon as the state says whatever they say tomorrow. So this is where we're kind of in this lurch, and I applaud what Nathan wrote. I think that the document that went out, the MAD, was well written, and I think it was appropriate. I think we need to back up a little bit and not just blanketly accept the state. The problem is that this went out accidentally to agencies by themselves, and then there was a confusion as to what to follow. So the answer is, you're correct. We do need to be all on the same page. I hope that by tomorrow we will be. Michael and then Nathan.
So I would just echo what Glenn was saying. I think that this document is an important document at the right time. And I think what we need to do is just have it as a trigger-based tool, right? So at some point, if we get to surge levels or crisis levels, standards of care, and we kind of have to clearly define that, then we can use that as an expected tool for how we take care of patients going forward. I think we have to be, I think that the hospital-based and the ICU-based literature in ethics of crisis standards of care is further ahead than EMS. And I think that we need to be in line with kind of the ethical standards of healthcare in general. So in addition to doing that kind of trigger-based assessment of the crisis standards of care, we need to also make sure to articulate what we're doing, why we're doing it, and why we're doing it so specifically. So I think that would be important. The other thing I would say, Glenn, and to the fire department, to the region, I think that there are other things that we need to think about de-escalating. One is the 10-minute rule. I think perhaps we can go back to, maybe it's time to reinstate the 10-minute rule for.
Yeah, that's on the list at the same time for phase 1.
And then the other thing is, and then this is a fire department question, but what about in the future as we go forward, kind of the idea of this hospital desk, thinking about where there's hospital surge and transporting to hospitals that are outside that. For example, in Queens, during the peak of the surge, would it be possible to bring stable patients to further places in order to decompress the primary transport to hospitals? It's an idea. I'll just put it out there, but it's something to consider for the future.
Yeah, we definitely looked at that this time around as well, but we can definitely further discuss.
Okay. Nathan, you had your hand up, waiting patiently.
Yeah, I just want to agree with what you did. You said what's going on right now is very confusing to the providers out there. And I think we're all in agreement that we don't have to go to the extremes that the state protocol does right now. So I want to make a motion for the REMAC to send out a letter just saying that the state guidelines are only if activated by the REMAC, and it is not activated at this time. So the providers on the street know they don't have to worry about getting in trouble for working up an asystolic patient for 20 minutes. And if the region decides we do have to go to some more extreme standard or some different standard, we can do it as a region and coordinate it and put it out at the same time, and not wait 3 or 4 weeks for the state to kind of catch up and go through their approval process and whatever they're doing over there.
Right. And I agree with you totally, Nathan. I think that actually, I have a draft. I'm hoping that it's going to be out by tomorrow. All right, Pesach, and then Paul.
I'm just going back to what you were just talking about, the surge transports and the 10-minute rule. Just anecdotally, something that's happened to me and to others recently, where we're forced to go to the closest hospital, and that closest hospital means that we're going to end up waiting there for 3 hours for a stretcher time and time again. And we're getting messages on our computer that say, try to avoid this hospital. But the rule is that we don't have a decision. We have to go to the closest hospital. So I think that forcing you to the closest hospital without any sort of without any sort of rationale, where it may be more prudent to go to a different hospital for the benefit of the system, not just for the benefit of the patient, is something that we need to look at in the future.
Okay.
Yeah, that's a great lesson learned, unfortunately, where we thought that now by eliminating the 10-minute rule, we'd be able to get ambulances to the closest and get them out. But I have to tell you, when you had hospitals that are clustered like 3 in an area, wasn't as big a deal. When you had one hospital in a neighborhood, and now they were the only closest hospital, I had calls during the peak from lieutenants who were on scene going, hey, doc, I've got 12 units here. They've come here because it's the closest, but now they're saying that it may take 2 hours for each unit to get processed. And so it actually backfired on us. And luckily it wasn't happening all the time, but what we thought was going to be beneficial, we learned the hard way that it wasn't actually as beneficial as we had thought. And so going forward, we need to plan in that we may have to eliminate the choice of going further, but we may have to allow them to at least have some kind of a choice, especially because crews know, I was just at hospital X and that place is going to take us 4 hours to get out of there. So why don't we try going here, because earlier wasn't as bad. So we definitely hear what you're saying, because unfortunately we saw that backfire a little bit.
Okay, Paul?
I want to just agree with Nathan on the impact on the providers on this, and I would just ask, from a forward-thinking concept, what is the impact the next state regulation comes down to us that seems absolute, which the back and forth on this alone, it was tough for me to agree with what was essentially medicine I didn't agree with in a region that wasn't required to do it, but it had a state letterhead on it. And I actually advised the crews to treat their conscience and let them, we would handle any perceived restrictions later if it was essentially an unenforceable edict by a non-physician declaring medical judgment in a region he doesn't work in. So what's the next thing that's going to come down from BEMS that we're forced to drink from the fire hose and take on a Friday afternoon? And how are we going to combat that? Can we use the language that Nathan wrote, like a higher standard of care? Because I'm fully supportive of that, because this was really not good.
So I think we should probably take that one step at a time. Number one. Number two is I think that there needs to be more collaboration, and I've argued this point at the state level where, you know, EMS physicians are not at the small round table around the commissioner enough. And we have to work on that going forward. But all these points are very valid. Jess, you had your hand up.
Why wouldn't redirection take care of the issue? Like if you do away with the 10-minute rule, why wouldn't just having redirection take care of the problem of crews having to wait 3 hours?
Well, you know, what we found was like that one hospital that was essentially getting everything because there's no other hospitals there. They actually now flooded that hospital, where in the past, you know, they could have gone somewhere else. Now they could not. And so now, instead of, let's say, 5 ambulances going there, you had 14. And so it backfired a little bit. And that's something that I wasn't expecting, but I definitely learned from that. So going forward, you know, we may have to have we're going to have some kind of a different plan that allows you to kind of go maybe to the next furthest hospital, because you know that, you know, there's already 10 ambulances there. The other place only had 2 or something like that. But that's how it happened. Again, if you have a cluster of hospitals that are very close in proximity, then the closest became, well, we're about as close to each this one or that one. But if you were the only hospital in the neighborhood, that was it. And that was happening to us, unfortunately.
So listen, I think we're all agree that, you know, having information come down from the state without any clear understanding of what's going on in our region is a problem. And it's something that going forward and in the future, we need to prevent from happening, both by better collaboration as well as by a better understanding from upstate as to what happens down here. I think we can all preach to the choir saying that we agree that this shouldn't happen this way. As far as lifting restrictions and getting back towards what we do on a regular everyday basis pre-COVID, I think we're working on it. I think we're getting there. I think that the challenge is when to pull these triggers, how aggressive to be, and how to do it in a proper way. It's already 7:07. We've been on this call for 2 hours, so there's a few more hands up, but I'd like to start wrapping things up. And after these 2 hands up, we'll just ask if anybody has any new business, and then we'll move forward. So first, Pesach, you have your hand up, and then Matt Smith.
I can for a second to redirection.
I understand you, Pesach.
Help situation.
All right, I just muted him. Pesach, we can't hear you because.
Can you hear me now?
Hello?
Can you hear me better now?
A little bit, yeah.
I can speak for a second to why the redirection may not help. That's because redirection has trigger points where you have to have a certain number of ambulances that are there for a certain number of time before it triggers. And there's one community hospital that I went to multiple occasions and sat for not less than 3 hours each time at that hospital. There was only 2 ambulances there, so it never triggered redirection for us. And then we cleared out of the hospital, and we get another patient a block away, and now there's no ambulances left at the hospital. We got sent right back there and sat for another 2 hours at the same hospital. And just the way the region system was working, it didn't trigger, even though the chief and the lieutenant were there with the hospital, and the hospital saying we can't triage you until another patient.
Not really understanding this.
Hey, Tuck, you're breaking up. I'm sorry.
Let's save this discussion for another time. This is operational.
All right. All right, Matt Smith.
Yeah, thank you so much. Just real quick, I just want to speak as a provider, you know, somebody who's been working the field during this, and I want to speak to the cardiac arrest guidelines. So my understanding is that what the state was saying is that if we have an unwitnessed arrest that's asystolic, we're not going to work it. And then obviously we said at the FDNY level that we do want to work it. And that's fine. The point I wanted to raise is, has anybody run the numbers in terms of the number of EMS providers that have gotten sick or died from COVID versus the number of patients that we would have potentially saved under those circumstances, in terms of just like the risk and the benefit? Because there's a real risk to the providers that are working these arrests up. And of course, that's a risk that we accept when we get into this field. And that's a risk that I'm happy to accept. But, the fire service has a motto that we risk a lot to save a lot. And if these are patients that have, a 1 in 100,000 chance of having a good outcome, then my question is that a risk to my safety and to the safety of my partners and my colleagues and my friends that is a good actuarial decision in the long run? And I just, I speak as a somebody from the field. So I just wanted to bring that up, and thank you all for your time.
Problem. So first, Michael has his hand up, but I'm just going to address what you said for a second, and then I'll pass over to Mike. I think that if you look at cardiac arrest literature, and there's a lot of it in the pre-hospital setting, and you look at what is appropriate thing to resuscitate, what is not appropriate to resuscitate, there is good evidence to support the decisions that were made at the state level. What I don't agree with, and what I think the problem here is the decision was made as a crisis standard in reaction to COVID, when our numbers are kind of going down and getting to the point where we should be managing these patients if that's what we were doing before. If we want to sit down at a protocol level or at a REMAC level and change our standards of care on the basis of the evidence, that's great. And I think that that's what we should do, but it shouldn't be done as a crisis change. It should be done with thought, with decision-making that makes sense, and then done in an appropriate way. To do it as a crisis standard is a different level, and that's where we run into difficulty. So Mike, I'm gonna let you speak, and then if there's any new business, we'll address that and then close up the conversation.
Matt, I appreciate your comment, because I think it's a very complex ethical question, and that concept of risk versus benefit, risk to the provider versus benefit to the patient, is an ethically complex one. Especially, I think that the problem lies in that you don't know, maybe when everybody is dying of COVID, everybody's dying of COVID, but you don't know what that patient has, and you don't know what they have. So I think the calculus of that, the ethical question, is big, and it, again, deserves a lot of attention. And I think that there will be that kind of literature put out there, because.
And of course, if a provider does die of COVID, you don't know where they got it. It could have been community acquired. It could have been from any patient. We don't know that it was a particular cardiac arrest.
Right. I mean, if you had 100%, I think it's the last comment, but if you had 100% guarantee that patient has had COVID and died, that's a different question than if they just had cardiac arrest during a pandemic. We don't know what the answer is. So, but again, those questions are multiple.
All right, Pesach.
Joe, can you hear me now?
Now I can hear you.
All right, I called back on my phone. I was just going to speak for a second towards why redirection may not address the issue of the 10-minute rule.
So one second, we heard it. It was, I think that the sentiment of what you were saying was echoed by other people as well. So I don't think we need to rehash it, but I think that it's definitely.
Okay, I didn't know that you heard anything.
Yeah, it's definitely that now with the lower volumes and the lower volumes in emergency departments, that we need to start thinking about when we go back to the way it used to be. But
absolutely.
Calling back. Sean, you have your hand up.
Yeah, just real quick, Joe. Thank you for acknowledging me. So now I think that we're all in agreement, obviously, that this was not the best way that the state sort of came down with things. But the problem is also that we echoed it, and we put it on letterhead in the 2020-10 version. So where are we going forward now? Are we going back to the 2020-08 advisory?
So I don't listen. There will be an advisory. I guarantee you it will come out before the next 24 hours are up. You will see an advisory telling you what to do in the region. I'm just trying to do it in a collaborative format with the state right now, rather than sending something out and having the state send something else out and leading to the same confusion that we have right now. So I'm willing to sacrifice a little bit of confusion today to have better clarity tomorrow. That's why I haven't sent anything out yet.
No, absolutely. Thank you.
I 100% agree that this was done in a very messed up way. The state has acknowledged that and accepted that and owned up to that. We just have to do it right now, and that's why it hasn't come out yesterday. All right?
Thank you.
But we will go to, I promise you'll have a clear standard for the region within the next 24 hours. Okay, Marie has her hand up, and then I'm gonna ask if anybody has any final new business. Marie, go ahead.
I just wanted to, I don't want to stir up trouble, but a lot of the problems that we're having right now is because the Department of Health is really not communicating with us on almost any level. They're having lots of conference calls that we go and sit on, and they talk at us, but they don't really allow our input. I was just on a conference call today, and I asked them about the CPR standards. I said, is this a protocol? Is it a guideline? Are we implementing it? And they just told me it's a standard. So they didn't want to answer my question. It's just something we need to work on, maybe behind the scenes, to get a better working relationship with them. It's just made it very difficult to function these past few weeks with them making decisions in a silo and then just throwing it at us, and we have to deal with it. So,
Paul, are you on a Peloton or something? I don't know. What? Paul looks like he's on a bike or something. All right. Any new business? I don't hear any new business, but if anybody has any new business, please speak up now.
My Apple Watch said I needed to stand up, Joe.
Good job.
Joe, just, what action should we take around this cardiac arrest standards of care? I know we're waiting for the state, and we'll go back to our original guidance, but moving forward, let's set up something to figure out.
So I will say, so to the whole call, because there's no secrets here, there is a draft advisory. I'm waiting just for the state. I spoke to Ryan today. He assured me that by early tomorrow, I will have a uniform document from them so that what we send out and what the state sends out all matches up. Essentially, we're going to go back to what we were doing before this crisis standard of care guideline came out, which is resuscitating all patients, doing 20 minutes of resuscitation with ACLS, and if there is no ROSC, we will not be transporting those patients. We'll go back to that standard for now, and eventually either use that as a standard or go back eventually to the full cardiac arrest standard. But that's where we're going to go back to. I'm just waiting to kind of be in line with the state so that there's not confusion that we send out something, then they send out something, and then people are just in a mess. So that is the plan.
I guess that doesn't answer my question. I think that yes, that's appropriate and we should do that. But just, again, setting up for the next go round, I'd be interested in working on how we do the trigger-based stuff and working,
So there are triggers that I guess I didn't understand your question. As part of the conversation we had on Sunday night, which is where the state admitted that they should not have rolled this out universally, there was a discussion as to trigger points to activate a crisis standard of care. It included level of PPE, it included the number of cardiac arrests, it included the ICU and hospital volumes in your region, and it would be activated regionally. So all of these trigger points were discussed. It was left somewhat vague so that there was some flexibility, but they were discussed, and there is going to be clear guidance as to what the triggers are going to be.
Sounds good.
I have no problem sharing it with everybody. I just don't want to share it before it is officially released because I think that leads to confusion. All right, working groups will share, but I don't want to share it regionally until we have it all in order. Is there any other new business? All right, seeing none, I want to thank everybody for joining us on this call. I really appreciate everybody's time. I know this has been an exhausting time for everybody. So everybody, please stay safe. And if you have any questions, Feel free to email myself or Marie at any point. Thank you all very much.
Thank you.